Hello, thank you very much. This is a bit of a graveyard slot and everyone wants to probably go to the pub. A lot of the stuff I'm going to talk about has kind of been touched on by other people, and so I'm going to go through some of it relatively quickly because I think a lot of the concepts have been addressed in some ways, and I'll just try and highlight the bits that are relevant to paediatrics. So the question that I was asked, which is a massive topic as far as I'm concerned, and I'll try and cover some of the elements, is can the NTB strategy deliver for childhood TB? And so what I'll talk briefly about, and again it's been covered a lot by others, is a bit about the transition from the Millennium Development Goals to Sustainable Goals and how the NTB strategy fits into this. And really the question is, why are we bothering? I mean, won't just dealing with adults be enough? And I'll hopefully convince you that maybe not quite, and that there are some interventions that we need to do that are paediatric specific. So I think everyone is familiar with the Millennium Development Goals, and we were quite lucky with the Development Goals in some ways in that children kind of came in a number of these areas. So we kind of, child mortality, great, we need to reduce that, but also, you know, child with TB, you get in with TB as well, and actually mothers and children, you deal with mothers, you get into the antenatal clinics, you get child and maternal health. So childhood TB was firmly on the map with the Millennium Development Goals. And so this is the last phase of the strategy here, and I think this has been dealt with previously. So what's happening with the Sustainable Development Goals? Well, I mean, there's less potential to access these in some ways, and I think we need to be a bit more creative about how we utilize these to think about how we motivate for TB and specifically for children with TB, because these are far wider ranging goals than the previous Millennium Development Goals. And so obviously there is Goal 3, and within that there are these 13 different areas. And within some of these there are areas that are applicable for childhood TB. So obviously the one that's been highlighted before is ending the epidemics of HIV and TB and malaria and others, but also thinking about preventable deaths in children, and some of the others also. I mean, we've heard so much this morning about all the other elements of society and poverty which become part of this as well. So I think we need to think about how we access other elements, the Sustainable Development Goals, both within the health goal but also within the others to improve the lot of children with TB. And again, we've looked at this, and what I'll do is I will refer back to this as I go through elements of childhood TB. And I think we've described the high-quality care, integration and prevention, the strategies and the research underpinned by these 4 cross-cutting elements to do with how we're going to implement them. And again, I think that we've looked at these elements to think that actually we can achieve a great deal by just implementing what we've got at the moment. I think if in 9 years' time we have a new vaccine, new drugs, and a point-of-care test, I think we'll be very happy. But even if we just do what we're doing now and doing it better, we'll be able to achieve a huge reduction in the burden of TB. So will focusing just on the adults be enough? I mean, the whole DOTS strategy really was focusing on smear-positive adults. If we deal with smear-positive adults, we will deal with the epidemic. It will cut down transmission. No one else will get infected. And this was very much thought to be the case for children. So if we deal with the adults with smear-positive TB, no children will get infected, no children will get diseased. And I think there was a feeling, you know, it has emerged over the last 5 or 10 years that that really wasn't sufficient, and that was failing children with TB. However, I think that if we, you know, the NTB strategy has the potential to really dramatically impact on childhood TB. This is a kind of schematic which describes on a logarithmic scale across the bottom the incidence of TB, 10 per 100,000, 100 per 100,000, 1,000 per 100,000, and the corresponding percentage of the burden that you see in children. So when you've got 10 cases per 100,000, only 5% of your TB burden is in children. When it goes up to 100 per 100,000, maybe 15%. And actually, when you get to 1,000 per 100,000 in a very, very high intensity areas, you're getting up to 40% of your burdens in children. And this is a composition of just having more children in those populations, a high force of infection so that children get exposed when they're younger, when they're at higher risk of progressing to disease. So if you do shift this curve from one of these areas across this way, if you just reduce the amount of TB in a community, you will sort of exponentially drop the amount of TB in kids. But this is probably not enough to really cope with TB in children. So what I'm going to sort of deal with over the next 20 minutes or 20, 30 minutes is some elements that I think are specific to children. And I'm going to go through these elements to really highlight some of the bits that are specific for pediatric TB. And some of these have been dealt with already by some of the other speakers, but maybe not with specific relevance to children. So the epidemiology of childhood TB. And I think this kind of comes into a number of the elements of the strategy. So we need to be monitoring, evaluating. We need to be putting strategies that are in place that are appropriate for the epidemic in front of us. And for that, any epidemiologist will tell you, you need to know what is going on, who's getting TB, where they're getting TB, how they're getting TB, and who's dying from it. And the reason why the epidemiology is important is we need to know who's getting it and where and when. This is important because it's only through that that you can target resources appropriately, whether they be drugs, whether they be tests, whether they be human resources. It also gives you the opportunity to say, well, this is how many patients you should be seeing, and this is how many you are seeing. Where is that shortfall, and why are we seeing that shortfall in this country or this district, but not in another? I think understanding the epidemiology of pediatric TB particularly is important because it's a litmus test for the rest of the epidemic. If there's a lot of TB in children, there's going to be a lot of TB circulating in the community because those children will have only been infected recently by prevailing strains. And I think that it's important to understand how many children and adults are getting TB, getting infected with TB and getting disease with TB, because actually we've all got to work with companies, drug companies, to motivate for innovation and for the production of new diagnostic tests, new vaccines and new drugs. And for that we need to be able to tell people how many, what their likely market is. And finally, for advocacy, people need to know exactly what the burden is to and where it is to advocate properly. And what's been exciting, I think, in the last 3 or 4 years has been a huge increase in our understanding of childhood TB. Up until about 4 or 5 years ago, the WHO didn't even mention or didn't even cite the number of children they thought had TB, and that changed. And then, but there still wasn't a really good estimate for mortality, and then last year they put out an estimate for mortality as well. And so things are changing dramatically, and that's a combination of WHO working very closely with a number of groups, academic groups and other actors, to try and come together to think about this more cleverly. So why is it difficult to think about the epidemiology of childhood TB? In this kind of diagram, you've got a picture of all the children who have TB. Only some of them ever get to a health service. Of those who get to a health service, only some of them get diagnosed with TB. And of those who get diagnosed with TB and start on treatment, only some of them get reported to the WHO. And in some countries with a large private sector, that's much higher than others. And it's quite challenging because in children, sometimes it's difficult to get respiratory specimens. Often they have porcine bacillary disease, so even if you do get that specimen, often it's not positive. In many places, the capacity to do more sophisticated culture-based tests is not there. And the real challenges in the under 5s, the young kids, who really they're the biggest challenge to make the diagnosis. And that's a problem confirming the diagnosis, but also there's a problem with underreporting. And previously, with the DOT strategy, it was a priority to think about smear-positive disease, and anything else wasn't really a priority for reporting. It wasn't even in some of the reporting guidelines or in the registers. And as I said before, private sector often didn't really play. And so this is something that we and a number of other people have been involved in with Pete to try and think of, are there other creative ways of estimating the burden in children. Previously, the WHO, when they first started estimating the burden in children, looked at how many children were reported to have TB, and they scaled it up by an underreporting factor. But I think a lot of people felt that that really wasn't doing justice and wasn't expanding by the amount it maybe should have done. So we took the other approach and thought, well, how many adults are there? And they must be interacting with children. They must be leading to pediatric infections. And of those children who get infected, a certain proportion, depending on age, HIV status, BCG status, etc., will progress to disease each year. And that gave us a kind of figure for how many children develop TB disease each year. And then working with a number of other groups who have also taken different complementary approaches, the WHO revised their estimates of childhood TB, and last year estimated that about 1 million children develop TB. And then there's drug resistance in children, and this is something that Pete and I have been working on recently to try and think not only how many children in the world get TB, but where are they getting TB, and are they getting TB with different drug resistance patterns? So this is the different WHO regions, and here are the proportion of cases that are drug susceptible, fully drug susceptible, that have isoniazid monoresistance, have rifampicin monoresistance, and have MDR. So you can see that in a lot of the world regions, the vast majority is drug susceptible, but in some regions, such as the European region, you're seeing quite a lot of MDR, even more MDR than isoniazid monoresistance. And then this diagram shows that of the cases that are MDR, how many of them are just MDR, and how many of them are MDR plus fluoroquinolones, MDR plus injectables, and how many are XDR. And again, you're seeing that in certain world regions, if you've got MDR, really you've only got MDR. But in some other regions, actually there's quite a high level of second-line drug resistance and XDR. And that gives us a burden of different types of drug resistance pattern in children. So I think it is quite simplistic to think of it as drug susceptible or MDR. It's much more granular in that respect, in that we need to think about each individual drug and whether the organism is resistant to those, because that gives you a much better understanding of what the burden is, but also what you need to combat that. And when you divide this then up by regions or countries, you get a much more sophisticated vision of what the epidemic's looking like. And this is where drug-resistant TB is in the world. So it's not rocket science to think, if you've got a lot of children and you've got a lot of TB and you've got a lot of drug resistance, that's where you're going to have a lot of children with drug-resistant TB. And it's, you know, if there's a lot of TB in Africa, but actually because there's a lot of drug resistance in certain areas in Southeast Asia, you're seeing a lot of children with drug-resistant TB. And so really your epidemic for drug-resistant TB is focused on those areas. And it's important to start thinking about that because that's where we need to be starting to target our resources. A separate piece of work which also we're working on is thinking about mortality. And the WHO have looked at mortality again from the bottom up rather than from the top down. And so they've taken the number of cases that have had vital registration, number of children who've been registered as dying of TB, and then inflated that number for sort of errors in case detection. Whereas we've looked from the other respect with, again, with Pete and with others at Harvard, we've taken this approach where we've thought, how many children get TB each year? Of those, how many get diagnosed? If you get diagnosed, what's your chance of surviving? If you don't get diagnosed, what's your chance of surviving? Is that modulated by HIV status or ART? And what we come up with is what I think is interesting. First of all, this is interesting. This is telling you where children die of TB each year, and it's a bit higher than the WHO's 150,000. It's more like 250,000 children die a year of TB. But if you look at these colours, the red is HIV-negative children who haven't been treated for TB. This purple is HIV-positive children who haven't been treated for TB. This tiny little green slip is HIV-positive children who have been treated, and the tiny little blue slip is the HIV-negative children who have been treated. And what this says is that the vast, more than 99% of children who die of TB are dying of TB because they've not been diagnosed and started on treatment. And yes, we need better drugs, and we need better formulations, and we need better regimens. But actually, the bottom line is we're not finding children with TB and starting them on treatment. And the vast majority of children each year who die of TB are dying because they're not found and they're not diagnosed. So I'm not going to talk very much on vaccinology because I think that was covered pretty comprehensively. But this kind of comes into a number of elements, including the research and innovation, but it does cross-straddle a number of these. And again, I'm not going to talk very much about this because Helen talked about this in a lot of detail, but a vaccine, huge promise, a lot of immunogenicity, but unfortunately didn't seem to show a huge efficacy in infants, and whether that's because it was the wrong vaccine or it was targeted at the wrong age group. And the reason I'm mentioning this is because actually in some ways, the reason why this is unique to children, or the issues that are unique to children, is that BCG only really works in children. It doesn't have an impact in adults. It doesn't have an impact on the epidemic. It purely protects young children from disseminated and severe disease. So when we're thinking about new vaccines, and there's lots coming on in the pipeline, which Helen's talking about, for young children, the vaccine has to be better than BCG. In older people, actually any vaccine that shows some efficacy is going to be of benefit. But for children, actually, we have to have something that's better than BCG. And BCG actually is not bad. In young children, it does have a significant, important part to play. And over the last couple of years, there's been significant international shortages of BCG, which we really need to actively campaign to address. Because at the moment, it's what we have, and it's very, it's pretty effective. Okay, so in terms of treatment, again, I'm not going to go over some of the things, but treatment comes in, again, research, but it also comes into the quality integrated care. It requires supportive systems, and it requires all of these to treat people with TB well. There are lots of types of TB treatment. So there's the treatment of TB infection, which Dave talked about a lot this morning. There's treatment of MDR TB disease, which has been talked about by Derek. We've talked a bit about preventive therapy for drug-susceptible infection, and there are specific issues to do with TB meningitis. And I'm going to touch on a few of these briefly with their relevance to children. So prizes for what this molecule is. Alison? What's yours? This is Repentant. So, I mean, this was a game changer that Alison mentioned earlier. As far as I'm concerned, this is one of the biggest things that could make an impact on TB globally, and specifically in childhood TB. And I am internally frustrated that this is not being rolled out more widely. So this is the big trial that was published in 2011 in adults. And as Alison described, the trial continued because there wasn't much data in HIV-positive patients, but there also wasn't much data in children. So the trial was continued in children, and what was found was actually in children like HIV-infected adults, it worked very well, and it was just as safe as in adults. So we have good idea that this works in children down to 2 years old. It's safe, it's effective, it's 12 doses once a week for 3 months. This potentially changes preventive therapy from something that's just a theory into preventive therapy that could be done, and yet it is not being used anywhere in the world, really outside the US, and even there it's not being used. And this for me is a huge sort of loss, one of the big kind of things that we could, as a community, take forward as something that will transform preventive therapy from theoretical to practical. So treatment shortening, there have been some really disappointing treatment shortening trials in adults over the last few years, trying to reduce the duration of therapy from 6 months to 4 months. And they didn't succeed in their primary outcome. They had some interesting secondary outcomes, but they didn't succeed. But this trial, the SHINE trial, will be starting in a few weeks, actually, which is trying to tease out children who have severe disease and limited disease, and just taking those with limited disease and randomizing those to conventional 6 months of treatment or 4 months of treatment to see if you can get away in children who just have more limited disease to 4 months of treatment. And I think this would be a really good progression. I mean, it's not a massive game changer, but 4 months is definitely better than 6 months. TB meningitis. So this is a systematic review and meta-analysis that Sylvia Chang did a couple of years ago of children with TBM. Your chances of dying of TB meningitis for your child is 20%, and your chances, if you survive, of having neurological sequelae is over 50%. This is a horrible disease. It's one of the nastiest things that I've had to deal with clinically, and it's a really unpleasant clinical problem. There have been a couple of interesting trials in adults recently. So this was published a few years ago in Indonesia, suggesting that actually if you give IV rifampicin at a higher dose and fluoroquinolone, actually dramatic increase or reduction in mortality. But unfortunately, this wasn't borne out with a trial just published a few weeks ago, done in Vietnam, which showed it's a moderate increase in the rifampicin dose, not as high as the Indonesian study, and fluoroquinolones didn't really show any improvement in outcome. There is a trial about to start in children, Kelly Dooley's leading, which is randomizing children to 3 different regimens, the standard of care, and then 2 regimens with much higher doses of rifampicin, including fluoroquinolones in them, and it'll be very interesting to see both the PK and the efficacy from this to come through. So again, I'm not going to talk about this. This is preventive therapy for MDR contacts. This is a bit of my pet topic, but I think Dave covered this comprehensively this morning with all the debates. There have been quite a few studies. I know he didn't sell it too well, but there have been quite a few studies, and I think there is a reasonable evidence base. I think that all we can say is that if you give contacts of MDR TB a fluoroquinolone-based preventive therapy regimen, it's generally pretty well tolerated, and if you do it, very few children get TB. I don't think you can say it comprehensively works, but I think you can say that. And as Dave mentioned, there is good news. There are 3 trials coming up, of which the TB CHAMP trial, which I'm involved in, is focused specifically in children under 5 years who have been exposed to an adult source case with MDR TB. And I think this will be a really interesting trial to try and identify whether this is something that does work. We're really hoping that it will show quite profound efficacy. So what about MDR TB treatment in children? So very poor evidence base. This is a recent collaboration which was done actually for the WHO revision to their guidelines committee. It was commissioned for them. And it really was trying to bring together all the cases of pediatric MDR TB anywhere, so everything published, everything unpublished, but do it on an individual patient level to then try and tease out whether there are certain characteristics of some children's treatment or their baseline characteristics which predicted outcome. And we're still in the very preliminary stage of analysing this, but the bottom line is outcomes are very good for children with MDR TB, at least 80% successful treatment outcomes. So again, it goes back to that image of children dying and where they are in the world. If you get found and you get diagnosed with TB, you get put on treatment, whether it's drug susceptible or drug resistant, you're likely to do well. The danger is the ones who are not being found. And we've got these exciting new drugs, which we talked about. We've got bedaquiline, we've got delamidid. Both of them have been evaluated by the WHO. Both of them have been given conditional recommendations, but the WHO have not recommended that either of these are used in children, which is very disappointing because actually there are many subgroups of patients who these drugs weren't trialled in and yet they've been given recommendations to use, but they've been explicitly not recommended to be used in children at the moment. However, people are starting to use them. We are starting to get case reports. Yesterday, I actually was chatting to some friends who are working in MSF in Uzbekistan who were talking about treating a 2-year-old with bedaquiline, which I was very nervous about, but they are starting to use it. And the problem is that these drugs have come in at a time where actually, really, by the time they were licensed, we should have a formulation, we should have known PK in children, so that you get the licensing in adults and then the child development should come very soon after. What we've got is we've got a situation where they're licensed in adults and actually we have got nothing. We don't know. We haven't even got a formulation we can give the children. We have no idea on the PK. We have no idea on the safety. These things should happen in a graduated way together, so by the time we've got to this stage with bedaquiline and delamidid, we should have drugs that are pretty ready to go for children. Delamidid actually is quite a long way ahead of bedaquiline. They've actually done some PK studies down to about 6 years of age. We have a bit of an idea of how to use that. Bedaquiline, we have absolutely no idea. But again, people are using them. People are also using the 9-month regimen in children, and we're using linezolid and clofazimine in children. We don't know how to use them. We don't really know what we're doing, but people are desperate. And if you haven't got drugs and you've got a sick child who's exposed to a resistant organism, people are using what they can. Lots of great MDR trials coming up. Again, I think these were talked about in some detail by Derek. Lots of exciting things going on, and there's not a single child recruited into any of these trials. And yes, it's hoped that if the findings come through, people will apply them to children, but children need to be included in these trials at an earlier stage. So, in terms of diagnostics, for me, the biggest part of diagnostics is finding the children in the first place. Once you've got a child in front of you, that's a challenge, but the biggest challenge is how do you find that child who might be there? And we have to go beyond passively waiting in the clinic for them to come to us. And I think this comes into part of care and prevention. It comes into interaction with the community and civil society, and it's about human rights and ethics. We need to be identifying children, and we need to be finding them. And household contact tracing is the way of doing this. It means that you go into a household of an adult who's been newly diagnosed with TB, and you screen the children and the other adults in that household. You look for prevalent disease currently, and then you look for high-risk children who have a high risk of progressing to disease. And it means you can treat them earlier, you prevent onward transmission, and you nip the epidemic in the bud. You can also help the family with education, give support for adherence, give infection control advice, and do various other bits and pieces. And if you're looking for kind of bang for your buck in terms of screening people, this is just the most effective way you can do it. So if you look at households of adults with TB, about 7% of them, nearly 10% of them will have prevalent TB at baseline, and nearly half of them will have a TB infection. And this corresponds to incidences which are so far, so 7%, that's what sort of 7,000 per 100,000. This is 40,000 per 100,000. These are very, very high rates. This is a much more successful approach than waiting passively or screening widely. And this is sort of courtesy of Jeff Stark, who this is a study from 50 years ago. Catherine Sue, even then, she was saying, and it's a no-brainer really, you get the adult clinics and the kids clinics, and you have an investigation team, and they do a bit of household screening, and then they look outside that. And her conclusion is basically, you find families show that TB exists in pools, public health should be directed at these pools, and that's a very effective way of doing it. So we've known about this for a long, long time. And this is advocated in every WHO guideline that there is, that we should be doing contact tracing and screening and giving preventive therapy, and yet study after study after study demonstrates this doesn't happen. And some of this is that preventive therapy is daily therapy for 6 months. That's very hard, so I think that Repentant does come into this, might make this much more attractive as a proposition to do. The second part of diagnosing TB is when you've got a child in front of you with symptoms, and they're symptoms that might be compatible with TB. And there are a few ways of diagnosing TB in this. Either you can look at the host response to the organism, and this is the way sort of IGRAs and TSTs look for the host response to it, or you can try and find the organism. Either you can find a phenotypic type, the actual bug itself, or you can find bits of the bug, bits of the genetic material. And once you've found the bug, either you can test it against different antibiotics to see if it's resistant, or you can look for genes that associate resistance, or you can do it all genetically together. And in terms of looking at host response, I think this is, these are the tuberculin, this is the old ways of doing it and looking at the more modern interferon gamma. But what I think is interesting is some of the newer gene expression work which is coming out, which is actually looking at, can you distinguish a child with TB from a child who's got very similar symptoms with pneumonia or malaria or cancer? And actually by using a small number of transcripts, you can discriminate pretty well between different disease states. So we produce a different immune response to TB as we produce to bacterial pneumonia with pneumococcus, as opposed to flu, as opposed to other things. And I think that maybe in 10, 15 years' time, we won't be trying desperately to find a bug in children. We will just be taking some blood and trying to see what their immune response is. And I think this potentially, down the line, if this is made much more applicable to a field situation, could have the potential to transform the way we diagnose TB in children. And then there's identification of the organism and resistance, and GeneXpert is an exciting progression. There have been an explosion of studies looking at expert in children, but I think we have to remember that it is quite limited. If you have 10 children who have TB, one of them might have smear-positive TB. 2 of them might have expert positive, and 3 of them might have culture positive. So you're still, even with the best type of microbiological and investigation, you're still missing the vast majority. And all the studies, they compare things like expert against culture, and they say, oh, it's got 85% specificity and sensitivity. Actually, it's not talking about all the cases you're missing as well. So I think we need to be really cognizant that actually the majority of pediatric diagnostics will remain putting the pieces of the jigsaw together. If you've got microbiology, great, but actually often it's a lot of different elements. And for that segues nicely on to the fact that we need to be doing better training. Actually, in the majority of the world, childhood TB is a bit of a black box and no one really understands how you diagnose it. It's not that complicated. And this comes again into a number of areas of the NTB strategy in terms of training. On the WHO website, there is this lovely childhood TB training toolkit. There's a whole booklet that guides facilitators in how they would run a training course to diagnose TB. There are 10 different modules going from epidemiology, diagnosis, etc., etc. You can download a slide set. This is a nice tool for taking these resources, adapting them to your local context, and teaching younger or junior clinicians and staff and health staff how to diagnose and treat children with TB. There are desk guides developed by the union. There are guides to read x-rays. I've recently been involved with developing an online course, again, having different modules. It's available in French and English, so you can click on these. It's quite nice. Here you sort of drop and drag. You play little games to try and understand the epidemiology in one. In the next, you have to take a history from this woman and ask her questions and see if she tells you the right answers, and you eventually make a diagnosis of TB in her child. And finally, you then have to decide on treatment. So you click on the pill box and it pops up a pill, and then you take pills away and you have to figure how many there are. So the resources are there to try and train people how to see children with TB and diagnose them and treat them. And we just need to encourage people to use them. And does it work? Well, yes. I mean, actually, you can train health systems to diagnose and treat more children. So this is a study in Bangladesh where there was in intervention centres and control centres looking at the number of cases that were diagnosed prior to the intervention. The intervention was sort of just training and help and support for the local practitioners. And you see a significant increase in the number of cases detected in intervention centres. You do see a bit of an increase in the control as well, but what you're seeing a big increase in is these smear negative pulmonary cases, the ones that are clinically diagnosed, from here 16 to 51 cases, and that's a really significant increase. That's the kind of cases that you need to be seeing increased in children. And their conclusion is simple guidelines and training basically increases your ability to direct children, increased detection. And this is another study in Tanzania with PATH and Unitaid. They started doing training. Before the training, the proportion of cases that were seen in children was about 7 or 8%, and that just quietly goes up. I mean, yes, it's possible overdiagnosis is happening, but the true amount is likely to be higher than 7 or 8%. So sort of finally winding up, integration is absolutely fundamental to this. Children do not present with TB to the national TB program. Children present with TB everywhere else. They present to maternal and child health services, they present to vaccine services, they go to the clinic where they have pneumonia, and unless there's an integration between that, TB programs will just miss children comprehensively. And I think that this is sort of, again, includes many of these, but particularly the integrated care and having many of these kind of coalitions with civil society needs to come into the integration element. And there's some nice documents that are describing how you integrate. And I think what's been happening recently, which is really good, is that many national TB programs are recruiting senior pediatric staff who traditionally have worked in the child and maternal health arena into the TB program to give advice, because previously these silos worked separately. We're also getting pediatric specialists in the WHO program reviews who will go and visit countries and give advice and make recommendations on which changes have to be made before Global Fund money is accessed. I think those kind of recommendations really help integrate the different services together. Integrating TB in IMCI, the Integrated Management of Childhood Illnesses, which is really the Bible for people at primary care level in most countries in the developing world, has to be flagged up that this is an option, because this is where children present. It's not to the TB clinic. So, in conclusion, I think that the NTB strategy will, on its own, if you just focus on the adults, result in a reduced burden of childhood TB. But I think that there really needs to be specific child interventions. And I think that understanding the epidemiology, which I think that generally is happening better and better, is vital. I think that we will ultimately need a new vaccine that is better than BCG to protect children. We'll need better treatments. But ultimately, the biggest thing is we need to find all those children who are currently unfound, diagnose them, and I think household contact tracing has a huge part to play in that. We need to train our healthcare workers to have the confidence to make clinical diagnoses in addition to those confirmed diagnoses, because if we just rely on confirmed diagnoses, we're going to miss the vast majority of children. And finally, I think that childhood TB has to be integrated from just the silos of TB programs into all the other elements of child health.